So most of you know the cardiovascular disorders. The epidemiological says it's a leading cause of death globally, almost 31% mortality. Indian studies, we do have a big burden, but we tend to have patients who are younger. 1 in 4 patients are less than 40 years. If you look at the coronary disease in the Asian population, the Pakistan, India, and Bangladesh tend to have patients who are on the lower. Bangladesh takes the credit for having the youngest myocardial infarctions. They tend to, the culinary habits are different. They overcook the food. They use less of greeny vegetables. Something like folate deficiency. They say there's some hypothesis. So the youngest heart attacks are more in Bangladesh, followed by India and Pakistan. So predicting cardiovascular risk in 21st century, in diabetes now you all know it's almost it's an epidemic. Proportion is reached. Lipids and hypertension, hemostatic and thrombotic complications, behavioral, inflammatory, demographic, and finally the genetic causes. So risk factors for cardiovascular disorders. We all know the higher the risk score, higher the rate. Most of you know the Framingham risk score, modified Framingham risk score, which comes from then we have something in the European side we call it's a ProCam score. So for whatever scoring is done for the Indian population it's doubled. Framingham risk score is there for Indian population. We need to double it. The ProCam score, what we have a risk factor stratification in the Europe, they tell the Indian population, Indian or the Asians needs to multiply it by 2.5. So that's the burden we are having in the subcontinent. But there are a few things, like 60% of the patients who develop coronary events in Indian population have only one or even none of the traditional risk factors. We do come across, there are a few cardiologists, my colleagues are here, they do come across patients are apparently having no risk factors. We are talking of traditional risk factors, end up having coronary event. So more than half either a normal, mildly increased lipid values. Majority of them we tend to come across no risk factors, lipids are normal, having an acute coronary event. So before I just want to give you some 2 case histories I'll present to you. He's a 35-year-old male software engineer from Hyderabad. He's come down for a weekend to Karimnagar to see his dad. He had ischemic chest pain, a window period of 2 hours, brought in the midnight to the casualty with an acute anterior MI. There were no risk factors for CAD. He's not overweight. We thought it's midnight. We thought pharmacoinvasive approach would have been strategy was better. I mean to say we tend to thrombolize the patient and do a PTC on the next day. So thrombolytic therapy with tenecteplase was given, and the next day facilitated PCI. We call that word facilitated. Done. The BMI was normal, non-hypertensive, non-diabetic, non-smoker. There's no family history of CAD. Troponin levels were high, indicating that it is a significant myocardial infarction. Echo showed an ejection fraction of 40%, and when we get our lipids checked, he was having near normal lipids with a HDL being around 38. I'll just show you the video of this. How you can see the proximal LAD pattern. What you see, it's almost narrowed part. The procedure. The wire is put for the LCX, and we have one to the LAD. And what you see between the 2 dots is the stent which are used for a drug-coated stent was put. And you can look at the procedure was done from the radial artery. In a few minutes, the procedure was done in a facilitated period next day. On the early next morning day we had done. So he has overall finally a good result for what he had. He has an open vessel and apparently no risk factors. I'll take you one more case which I want to tell you. So yet another patient, 28 years. We do come across acute myocardial infarctions, and on average in a week we get less than 40 years. One patient I'm seeing in my clinical practice. Others colleagues also would probably see them. 22-year-old MBA student came with a chest pain. ECG revealed an acute anterior MI. Window period was 4 hours. We were taken for a primary PCI. Patient had no risk factors for CAD, lean body mass, non-smoker, non-hypertensive, non-diabetic, no family history of any premature CAD. And ECG was showing extensive anterior MI. His ejection fraction was much lesser, 35%. Troponin levels again showing more than 50, and all the biochemical parameters were normal, including the lipid profile. Showing a view in the AP card, you can see the LAD is almost cut off. So proximal portion of the LAD is cut off. We tried to pass a guide wire. BMW wire was passed. And procedure was again a drug-coated stents were used, and results. It was a good result for. Technically, it was a good result. This is a young man of just 28 years. What trend we are seeing here? I don't know. Most of the colleagues will agree with me. These 2 patients came to our hospital. Both were brought up by their fathers. Their fathers are 65 years. Both of them. They're quite healthy people. And they're asking me why my son is having a cardiac problem. This probably we are facing a lot of thing. Young coronary artery disease, parents coming to the hospital and just requesting. We didn't have an answer because most of the traditional risk factors were missing. Yeah. So this chart, I think most of you see traditional risk factors. Most of you are aware of it: age, diabetes, smoking, hypertension, dyslipidemia, obesity, lack of exercise, and a premature family history of CAD. That is a very strong predictor. And newer risk factors. So what are the non-traditional risk factors people have? Something like abnormal ankle brachial index, chronic inflammation, which I'm probably going to talk about it, homocysteine levels, microproteinuria, albumin creatinine ratio, metabolic syndrome, left ventral hypertrophy, renal disease, calcium scoring. Now this is the thing, getting a calcium scoring. CT calcium scoring is being done frequently in most of the cardiac clinics. Chronic inflammatory diseases, CRP. I just wanted to emphasize about CRP today. I'm going to tell you about fibrinogen, lipoprotein, HIV, and BNP, which is a biochemical marker. All these things, you look at the thing, it's still the traditional risk factors which have a lot of weightage. I went through the bulletin of 2014 AHA bulletin. Just look at the conventional risk factors. Most of you are aware of it. I don't want to discuss about it. Modifiable risk factors like high blood pressure, high cholesterol. The non-traditional risk factors are C-reactive proteins. High levels are related to the presence of inflammation, and according to research results, may be associated with increased risk of CAD, development of heart attack. Lipoprotein A, it's a very atherogenic. This thing, Indian population, the inter-heart study has shown the lipoprotein is one of the biggest culprit for the Asian population to have coronary events. Homocysteines, yeah, vascular disease, DVTs, and so many other things. I'll tell briefly in the next few slides. In general population, mild to moderate elevations are due to insufficient dietary intake of folic acid, but homocysteine levels may also identify people at increased risk of heart disease. And we Indians are also having something like a subfraction of LDL. It's called small dense LDL. It's more atherogenic than the larger particle. So we tend to have small dense LDL. Indian population is going to have. Then I think the last one is the fibrinogen. I couldn't see it here. Fibrinogen. So, and this bulletin has some interesting findings, which I thought the various medical conditions that can contribute to CAD include the following: end-stage renal disease. Most of you are aware of it. Most of the CKD patients, 70% are going to die of a coronary event. Chronic inflammatory diseases affecting connective tissue disorders like lupus, rheumatoid arthritis, HIV, highly active antiretroviral therapy. If you give a higher, this is also a big thing now. Patients getting a highly active retroviral therapy end up in acute coronary syndrome. Xanthelasmata, most of you are aware of it. Raised yellow plaques around the eyelids, and the following are also considered to be risk factors like tissue plasminogen activator. There is an imbalance of the clot dissolving enzymes and the respective inhibitors like plasminogen activator inhibitor PI1. They all predispose to individuals with myocardial infarction. There is an imbalance between the tissue TPA versus the inhibitors. Low testosterone levels, and it's an important thing. I'm going to tell about this. Have a significant negative impact on the patients with the CAD. When we say a patient has an MI, we always write risk factor: hypertension, diabetic, male sex. Now probably don't need to write a male sex. We should tell low testosterone levels. Hysterectomy, some data is there. I'm going to tell you that. Lack of sleep has been added now as a new modality, a new risk factor for coronary artery disease. So essential update from the ACC 2013 changes. What are the changes and recommendation? Stroke is added to the list of coronary events traditionally covered by risk prediction equations. It's a new thing. Stroke. If somebody has got a stroke, and you likely to have a. So the guidelines focus primarily on the 10-year risk of atherosclerosis related events. They focus secondarily on the assessment of lifetime risk for adults aged 59 or younger. And the strongest predictors for 10-year risk, I told you, Framingham risk score, modified Framingham risk score, ProCam scoring. They use all these variables like sex, race, total cholesterol, HDL, blood pressure, and diabetes and current smoking status are used, and they have a formula which tells you that what risk you have at 10 years, at 20 years, or what risk of this thing. And adjuvant formulas for refining risk estimates for gender, race are provided. And if risk prediction needs to be further sharpened after risk prediction equations have been performed, the guidelines indicate the coronary calcium artery scoring. This is a new thing, most of the things, calcium scoring on a CT scan, which is done in our hospital. Just walk in, you can get your score. How much is your calcium score? What is your risk of developing a coronary artery disease? Family history, high sensitive C-reactive proteins and ankle break index. These are the emerging markers what we tell. If somebody CCC calcium scoring, family history, C-reactive proteins and ankle break index. This need to be given importance according to the bulletin what they mentioned, and the guidelines recommend that statin therapy be considered to individuals whose 10-year atherosclerotic CVS risk is more than 7.5%. So all of them, irrespective of this thing, if he's got a 7.5% risk in the next 10 years, he merits an statin at bedtime. So what is inflammation? Is there any history for it? The Austrian pathologist Karl von Rokitansky and German counterpart Rudolf, they had a difference of opinion. So Rokitansky was telling that it's all inflammation is secondary role to the arterial changes what we see. But Rudolf Virchow, from beginning he was telling that considered to be the inflammation is the primary importance. Did we get resolved? Even in 21st century, we are still unresolved. We are still looking at the traditional risk factors. How vascular inflammation be measured or quantified? We don't have an answer. How can it be reduced or modified? It's all too nascent to make a statement. What are the important markers? Which I'll tell you what few important markers we're going to tell you. Will measures reduce the inflammation after the risk of atherosclerotic heart disease? By reducing these markers, are we going to get a clinical benefit in such patients? These are all questions need to be answered. So inflammation pathogenesis, you can look at the lumen, endothelium, the activated monocytes, followed by the entry of LDL in the inflammatory site. And the single most important in the inflammation is the oxidation of LDL, which works, it's a trigger for inflammation. Okay. Then how oxidize LDL, which acts on the monocyte and dendritic cell. There are two pathways, NF-kB pathway and kynurenine pathways. How it evolves, how the inflammatory mediators are released like CRP, tumor necrosis factor, interleukin 1, 6, then other additional molecules like selectin P or a VCAM or ICAM. So this is a general pathway, like how just briefly I told you how inflammatory pathogenesis causes atherosclerotic changes. In the lumen, we need anti-inflammatories like statins, where exactly all the drugs work for you. Probably TNF inhibitors, where inflammatory mediators are going to be like suppressed. The CAN-Q, this is going to be very important, which I'll tell you in a few slides. So what are the infective causes? Today, if you go for an endoscopy, for a GERD symptoms to Asian Institute of Gastroenterology, I think before you get an endoscopy, they will ask you for a serological test for a H. pylori. I mean, this is a trend. We probably in a few days' time, we might have something like that. Infectious disease may play a role in CVD or may intensify the effect of other risk factors. The association of CAD and chlamydial pneumonia is firmly established. Other infectious agents, conditions like CMV, herpes simplex, H. pylori are also said to have effect on the causing CAD. But the causality is yet to be proven. CMV is implicated more strongly epidemiology by in vivo detection. All the above mentioned links between CAD infections can be determined by large and perhaps lifetime prospectus. We need a lot of studies to tell, but as in today, chlamydia, CMV has some serological evidence to tell you that infective cause for myocardial infarction. Chlamydial pneumonia, discovered in 1986, most of you know it's an obligate intracellular pathogen. Serologically, we can identify by getting the seropositivity. You ask them for an antibody to chlamydia, we can identify. And pathologically, from the Cochrane data, 46 out of the 50 trials, there was pathological evidence of chlamydia in the atherosclerotic plaque. Many clinical animal studies are now correlating with human studies lately. The seropositivity, when somebody's got a positivity, say antibody positivity, there's a 4-fold increase in developing atherosclerosis. And further studies are all necessary to prove causal relationship. And by far the culprit, most of them aware CRP we've been telling, C-reactive preventive. It's one of the hallmark biomarker today in investigation. So raised CRP is a sign of inflammation. Inflammation process appears to contribute to all the stages of atherothrombosis, plaque formation, rupture. So reference value for CRP, if somebody's got less than 1 milligram per deciliter, he's got a low risk of developing CAD. 1 to 3% intermediate risk, more than 3% high, he comes in the high risk group. But if somebody's got a CRP levels more than 10, think of some collagen vascular, rheumatological, chronic inflammatory diseases you should consider. Jupiter trial, most of you know, the hallmark trial for a rosuvastatin, telling that primary prevention, that trial told you that even rosuvastatin could work as a primary prevention, this thing. In that trial, when you look at the subsets classification, it has shown that patients who are having a normal LDL with a raised CRP, the benefit was there. The endpoint benefit of stroke, recurrent admissions or a death was reduced when these statins were given. We're talking of rosuvastatin. Then few studies were there, like Air Force coronary artery prevention studies and Texas coronary artery prevention studies. They used a lower statin, and these patients, they use patients who are having a normal LDL and having a high CRP. The benefit was there in that subset of patients. But if somebody had a normal LDL with a normal CRP, the benefit was not there. So there are enough lower statin, Jupiter trial, AFCAPS and TEXAPS, these studies have shown, and statins reduced high sensitivity. Among all the statins, rosuvastatin scores or other statins. Conditions you should remember where CRP levels can be high: acute inflammatory conditions, tissue injury, necrosis, metabolic syndrome, malignant tumors, pancreatitis, burns, post-surgery, hormone replacement therapy, and leukemia. So Center for Disease Control, CDC, what does it say about his CRP? What are the take on that? So the measurement of C-reactive may help direct further evaluation and therapy in the primary prevention of CVD. The entire adult population should not be screened. They say it should not be screened in 2003. Measuring CRP is apparently healthy elderly people to identify cardiovascular risk. In 2010 and 2013, the use of CRP for stratifying the high-risk patients for atherosclerotic cardiovascular. In those high-risk patients, you can investigate a patient. If somebody has an acute coronary event with normal lipids, and you can get a HSCRP levels to this thing, but for not routine clinical evaluation may not be the answer. Lipoprotein A, most of you know, it's a glycosylated, it's almost identical like LDL. Amino acid sequence is very close to plasminogen. The analog is very homologous with plasminogen. So it causes thrombosis in young people, persons with hyperlipidemia, and it binds to fibrin and blocks the fibrinolytic action of plasma. Anything more than 30 milligram per deciliter, treatment is necessary. Target LDL-C indirectly, and lipoprotein mainstay of treatment is reduction of LDL-C. That will reduce the lipoprotein. Statins mainstay, niacin also helpful. So CRP and lipoprotein. Lipoprotein is very atherogenic. I told you, inter-heart study has shown that almost 30% of the Indian population, the Asian populations have a high lipoprotein. Most of the labs today have lipoprotein assays are done in most of the corporate hospitals in city today. Homocysteine, most of you are aware of it. Homocysteine causes peripheral vascular disease, strokes. A lot of neurologists look for homocysteine, hyperhomocysteine levels. Then peripheral vascular disease I mentioned, DVT is known, fractures are known, neuropsychiatric symptoms are quite higher. It's a product of folate metabolism derived from the sulfur containing amino acid methionine. It's got its cofactors are there, B6, B12, these cofactors, and with folic acid. You know the importance of folic acid, premature deliveries, neural tip defects, all these things have a role. Homocysteine, anybody has more than 15 milligram per deciliter, it stands an independent risk factor for PVD, stroke, and MI. But lately the data has come from All India Institute of Medical Sciences and one from Care Hospital saying that homocysteine relationship with coronary disease is not very well, it's a negative. So we still hold goods for PVD, stroke, and some high risk patients only. Kind of conditions where the hyperhomocysteine occurs, the OCP patients who are on OCP, niacin, taking niacin, any antifolate drugs like phenytoin, methotrexate, and theophylline. So how does this homocysteine cause? It activates like a protein C. It activates the protein C, impairs the nitric oxide release from the endothelial cells, stimulates the proliferation of smooth muscle cells. And there's some studies like vitamin intervention in stroke prevention, physician heart study, Norwich study. All these have shown that supplementing folic acid, the studies were like that. They gave only for some patients folic acid, B6 was given, B12 is given, but individually if you give, there was no benefit. But if you look at the patients who received all the three, the benefit was there, the endpoint reduction was there. But only the HOPE-2 trial, I think most of you are aware of it, the vitamin supplementation has much benefit except for some decreasing incidence of ischemic strokes. Fibrinogen, high fibrinogen levels are also known to cause, it's a direct relation with atherosclerotic vascular disease. Anything more than 350 milligram per deciliter. The trials, the Norwich Parks Heart study, Goldberg study have shown that there's a 4 to 5-fold increase in myocardial infarction and stroke. And treatment essentially going to be fibrates, pentoxifylline, polyunsaturated fatty acids, and anabolic steroids. Now there are some emerging markers. We use BNP levels for heart failure, but it's picking up in a big way in an ischemic heart disease. In a 10-year comparison of 10 biomarkers for the predicting death and major cardiovascular events in approximately 3,000 individuals, The most informative biomarker for predicting death levels was BNP level and CRP, homocysteine, renal levels, urinary albumin to creatinine ratio. The most informative biomarkers for predicting major. This could be the future. I don't know. I'm not doing much in the coronary events. In heart failure, we do get BNP levels to prognosticate the patient. This could be the future. I feel the BNP levels and the urinary albumin to creatinine ratio is going to be a future emerging biomarker to as a risk factor for heart disease. P-selectin, common therapeutic agent of CVD, belongs to the family of selectin addition molecules and is expressed by the platelets and endothelial cells on stimulation. Therefore, treating molecules such as P-selectin contributing to coagulation and inflammation may offer novel therapeutic strategies to treat CVD. MPO, myeloperoxidase, it's a protein which is during the activation of and degranulation of neutrophils, it is released, and MPO levels shown to predict. If somebody has got a high risk group, if we get his MPO levels, we can really predict, it can prognosticate a patient. If somebody's got an acute MI with a high MPO levels, the hospitalization is going to be higher, outcome is going to be much. These are all observational studies. We need a lot of data to prove all this. So we have been told a lot of vitamin D. Vitamin D is going on, plus or minus what. We just took one data, that prospective cohort study, Kestenbaum et al. They measured, and the outcomes included myocardial infarction, heart failure, cardiovascular death, and all-cause mortality. So vitamin D deficiency was associated with increased mortality in myocardial infarction. Each 10 nanogram per ml drop in vitamin D was associated with 9% great increase in death. So 10 to 10% roughly we have. And parathormone excess is again shown to have refractory heart failures. The Copenhagen City Heart Study found that xanthelasmata, but not the Arcus corneas, constitutes an independent risk factor for CV, cardiovascular disease. Presence of xanthelasmata indicates increased risk of myocardial infarction, ischemic heart disease, and severe atherosclerosis. So medical conditions such as end-stage renal disease, chronic inflammatory, I mentioned that lupus, rheumatoid, HIV, heart treatment, they're all the markers of inflammation probably is going to be useful in such patients. And you see most of the patients on hemodialysis either die of a coronary event or an intracranial bleed. ESRD is associated with anemia, hyperhomocysteinemia, increased calcium phosphate products, calcium deposits, hypoalbuminemia, increased troponin levels, increased markers of inflammation, increased oxidant stress, and decreased nitric oxide activity factors, all of which contribute to have a CAD risk. Now, US, you see in endocrine calcium metabolism, the HRT clinics were running very well in the 80s. In the 90s, the US government has stopped the HRT clinics. Now they started the TRT clinics. It was actually the Andropos clinic, they started as Andropos clinics, the human rights violation. They said some gender, this thing they had to taken off now. They're called TRT clinics. So epidemiological evidence has confirmed that testosterone has a positive association with HDL cholesterol and inverse relation with hyperlipidemia. Most studies reported inverse relation with low levels of testosterone, and studies have demonstrated that testosterone can have a positive effect on reducing the risk factors CV, CAD, and you can see number of TRT replacement therapies, clinics being opened in the western side. We all know the hysterectomy and bilateral sulfing oophorectomy, what are the risk factors. There are a lot of data this way, that way, but the largest study came from the Mayo Clinic. They followed 8,000 patients post hysterectomy for about 20 years. They found that patients who underwent hysterectomy less than 35 years, they stand at a high risk for CAD. Now the sleep, lot of data is coming. The sleep systemic review and meta-analysis by Capicio et al. Suggests that sleep hours less than 5 to 6 hours or more, sleep exceeding more than said to increase the risk of CAD. So make sure you have an 8 hours sleep per day. And the population-based study, Loxand et al. Found that insomnia is associated with moderately increased risk of acute MI. With all these traditional risk factors and emerging inflammatory markers, we still 90% of the time we are discussing of traditional risk factors. This has a future. This has a future. We are too early to say this. Maybe this talk could have been relevant if you've done another 4 years later or something. Some immunomodulatory, immunosuppressive promising therapies such as cyclosporine, colchicine they've been trying. The Chinese people are trying magnesium sulfate in acute MI today. So a lot of data is coming. We really don't have any causal relationship for all this. Methotrexate, anti-proliferative, anti-inflammatory effects being tried out. Trials, low-dose methotrexate in acute MI. It looks strange, but there is all trials. SIR trial evaluated low dose in high prevalence of subclinical vascular inflammation. Probably the important thing is going to be the CANTOS study, which evaluated the canakinumab in patients with CAD in persistently elevated CRP, and the blockage of other potential targets such as interleukin 6, CC2, chemokine receptor, CD20, and could bring benefits of CAD. And concluding, despite optimal therapy with current drugs, still 1/3 of the low risk individuals having a Framingham risk score have been known to develop ASVD, asymptomatic cardiovascular diseases. Tackling inflammation provides potential to improve cardiovascular outcomes further. Some molecules targeting inflammation are being developed to provide a unique addition to. So before closing off, I just want to tell you, calcium scoring can be done on the regular OP basis. You can walk in, it does not require any diet or anything. You just calcium scoring. If somebody's got a less than 100 score, low risk 100 to 300 is accepted. The agastatin score it's been based on that. Anything above 300, you have a clinical relevant coronary disease. It's by far the easiest thing. A lot of data is coming up saying that BNP levels, calcium scoring, ankle brachial index are going to be the future biomarkers to predict cardiovascular event. And clinical practice, don't mistake. We have been told so many of inflammatory mediators. We still have 90% of traditional risk factors. Try to control the lifestyle, treating with high statins. Whatever procedures required like CAG revascularization have to be done on time. And this could be a future, that's what I'm trying to tell you, but we need to have something like CRP, lipoprotein A. These are going to be, at least we need to get evaluate such patients who are high risk patients where risk factors are not really established. Thank you for the patient hearing.